I'm going to be speaking on emergency ultrasound in the second and third trimesters of pregnancy. Emergency ultrasounds may be required in several situations. They may be required because the patient has symptoms such as bleeding, pain, or cramping. They may be required because of an abnormal physical finding on an examination with a clinician, such as a shortened cervix or elevated maternal blood pressure. Or they may be required when there's concern for the fetal well-being, such as decreased fetal movement or abnormal fetal heart rate patterns. When bleeding occurs in the second and third trimester, ultrasound is used to assess for placental abruption and placenta previa. A placental abruption is premature separation of the placenta. It occurs in about 1% of all pregnancies, and it is the most common cause of intrapartum fetal death, accounting for 15% of perinatal mortality. It also may cause problems for the mother, including maternal coagulopathy. The mother typically presents with symptoms of pain, bleeding, and sometimes contractions. The ultrasound findings when a patient has an abruption can be normal. This is found in about 20% of cases. In 80% of cases, a hematoma will be identified in the vicinity of the placenta. It may be in a subchorionic location tracking away from the placenta. It may be behind the placenta, or it may be in a preplacental location with the blood tracking anterior or on the amniotic side of the placenta. In addition, echoes may be seen in the amniotic fluid due to blood that has seeped into the amniotic cavity. Here's a retroplacental hematoma from a placental abruption. You can see a hypoechoic lesion sitting behind this edge of the placenta, which is here, and lifting up that edge of the placenta. On a different view of the same abruption, you can see this hypoechoic irregularly shaped collection beneath the placenta, representing the hematoma from the abruption. This patient has a hematoma adjacent to the placenta. You can see the placenta here posteriorly, and then adjacent to it is a lesion that has almost the same echogenicity as the placenta and might be confused with an extension of the placenta. If, however, we add power Doppler to the image, you can see that while there's some flow inside the placenta, there's no flow in this homogeneous mass that is a hematoma but looks like a placenta. And we can confirm the fact that it's not the placenta by watching this hematoma move when the baby kicks it. You can see it's a gelatinous type substance that jiggles as the baby's extremity bumps up against it. This patient also has an abruption and developed a preplacental hematoma. You can see this crescentic collection anterior, or not anterior, but in the amniotic side of the placenta. And notice how it too has a gelatinous type appearance that jiggles as the baby kicks the hematoma. Placenta previa occurs when part of the placenta or all of the placenta covers the cervix. And in particular, it may cover the internal cervical os, or it may extend close to the internal cervical os, covering part of the internal surface of the cervix. If you look at the obstetrical definitions of placenta previa, they're listed here. A complete placenta previa occurs when the placenta covers the entire internal cervical os. A partial placenta previa occurs when the placenta partially covers the internal os. A marginal placenta previa is defined as occurring when the placenta ends at the margin of the internal os, and a low-lying placenta extends close to but does not abut the internal os. Unfortunately, ultrasound cannot be as precise as these obstetrical definitions. Why not? Well, ultrasound cannot determine the exact location of the internal cervical os. It cannot determine the exact extent of placental implantation versus overlap of some of the placental tissues against other tissues. So as a result, ultrasound cannot distinguish marginal from partial previas. So for practical purposes, ultrasound terms should be limited to complete placenta previa, marginal placenta previa, and low-lying placenta, and the term partial placenta previa should be avoided. A complete previa is when the placenta covers the entire cervix, a marginal previa when the placenta covers part of the cervix, and a low-lying placenta when the placenta covers only a part of the cervix earlier in pregnancy. Well, marginal versus low-lying placentas, both of those terms can be used for placentas that extend close to the cervix but do not cover the internal cervical os. In practice, whichever one you use, remember to report the distance from the edge of the placenta to the internal cervical os. A complete placenta previa occurs when the placenta covers the entire cervix. That is, it covers the internal cervical os and extends beyond it. Some placenta previas that are complete are central, and some are asymmetric. When they're central, the placenta is centered over the cervix, and when they're asymmetric, a large part of the placenta is on one side of the cervix, while a smaller portion extends to the other side. So here is a central, complete placenta previa. You can see on this view of the lower uterine segment that we have placenta along the anterior surface of the lower uterine segment, crossing the cervix and extending posteriorly. You can see the cervix beneath the placenta with the internal os marked with the arrow on the grayscale and the color view, and the cervical canal extending down from that point. With marginal or low-lying placentas, the placenta covers part of the cervix. Here's a case of a low-lying or marginal placenta previa. You can see that the internal os is marked with the arrow and that the placenta ends close to the internal os, less than 2 centimeters. Notice also with the color Doppler that the hypoechoic areas that you see at the edge of the placenta are actually vessels, some of which are part of the placenta. This is a transvaginal view of the placenta and the cervix showing another low-lying placenta. You can see the cervix and the cervical canal. The calipers are placed on the internal cervical os and the edge of the placenta, as we see here, and you can see that the distance from the edge of the placenta to the internal cervical os is only 1.3 centimeters. Transabdominal scanning is the first way to assess for placental previa, but it doesn't always work. The reason for the pitfalls of abdominal scanning are listed here. You may have placental vessels that mimic a membrane separation when in fact there is blood flowing in those vessels. You may have a lower uterine segment contraction. If the maternal bladder is overly filled, that will limit the transabdominal scan, and very often the fetal head will be overlying the cervix, obscuring it. Here's an example of a contraction mimicking a placenta previa. At 8:32 in the morning, this patient was scanned, and the anterior placenta appeared to extend close to what looked like the internal cervical os, and here you can see what looked like the cervix. But by 8:56 now, you can see that now that we have a better view of the placenta and the contraction has disappeared, the placenta is far from the cervix, ending well away from it, and no evidence of a previa. Here's the transvaginal scan a few minutes later, again showing the cervix, the internal cervical os, and no evidence of placenta anywhere near the cervix. On transabdominal view, sometimes the fetal head will obscure the cervix. You can make an effort to lift the fetal head to try to get a view of the cervix, and then if that fails, of course, you can do a transvaginal scan. In this case, we could not see the cervix because of shadowing from the fetal head, but we put pressure on the fetal head, and you can see that with the pressure, the fetal head is lifted, and this patient actually has a placenta previa. You can see the cervix here, the internal cervical canal, and the placenta overlapping and attached to the edge of the cervix. Now, if the transabdominal scan is inconclusive, a transvaginal scan should be performed unless it is contraindicated, in which case a translabial scan can be done. Here's a patient who had a transabdominal scan. You can see that the evaluation of the placenta was not possible because the fetal head obscured this posterior placenta. But a transvaginal scan was performed, and you can see now a good view of the cervix, the internal cervical canal, and the internal os, and you can see that the placenta extended all the way up to the internal cervical os.